So thank you very much, everyone, for joining me today in our weekly session. So I welcome you all to our today's 5 ultrasound cases series. And I think we are running this session for last 6 months already. So we have made a couple of videos, and all those videos are obviously available on our YouTube channel. So I'm Dr. Mahin Ashraf from Bangladesh. And if you're new to this program, we run this program on every Friday at the night time in my local time, but it may differ from the areas where you are from joining from. So anyway, we have a YouTube channel named Imaging Study, and if you go there, you can find our previous sessions. So all the sessions are already there uploaded. So you can just go and get whatever you want. We have already got 64K plus subscribers with 480 plus videos uploaded there. So we invite you obviously to join us there so that we can communicate and share our knowledge with you. And obviously your comments and your suggestions are very much valuable for us. So anyway, yeah, let's start our today's first case. So today we will discuss, as usual, 5 cases, and hopefully some of these cases may be helpful for you during your regular practice. Anyway, let's start with the case number 1. This is a 13-year-old male patient who came with severe left hemiscrotal pain and swelling. So it was an acute case, and let's see what we have got on ultrasound. So during the scanning, our clinician sent us this patient to exclude testicular torsion. He was suspecting either it's a torsion or epididymitis. Obviously, these two are the common differentials. And yeah, let's look at the image. So here you can see this is the right testis and this one is the left one. Obviously, the left one doesn't look normal. The right testis volume is quite like 10 cc, and it's the left one is 15 cc. It's quite round in shape. The texture is also heterogeneous. You can see some hypoechoic areas. Obviously, if you change the preset to any other preset, you may get better image, obviously. But for primary observation, the left testis doesn't look normal. We want to put Doppler to understand the vascularity. And obviously, you can see some collection within the left hemiscrotal sac, which may be also associated with torsion or inflammation. So we need to evaluate much more in such cases. So let's jump into the Doppler. After putting the Doppler, we were a little bit confused. Now you can see the right and left testis with similar PRF setting looks quite normal for the vascularity. If I say this vascularity is normal for a testis with a very hypovascular appearance in such cases, the left one looks quite similar. You can see some vascularity here. So it doesn't look like a case of torsion. Now, that is the confusion that started just looking at this image. So we are not satisfied. We want to do some pulse wave checking. So we took sample from the intratesticular tiny vessels. So both are showing the arterial wave pattern. You can see some diastolic flows. Obviously, in case of torsion, you may get flow from the cremasteric or differential arteries, but those arteries or their branches usually won't show you any diastolic component. Whenever you see a testicular flow having a good diastolic component, it's usually the branch from the testicular artery itself. So this testis is having supply within the parenchyma through the testicular artery or its branches. So we actually can say that there is very less possibility of torsion in such situation. But obviously, it's not a case of orchitis also. So what we need to evaluate right now, because we have seen the hydrocele, we can see the testis is quite swollen and heterogeneous, but still there is a normal vascularity, which is a little bit confusing. Now we want to see the epididymis to make a conclusion. So let's jump into another preset. So whenever I feel confusion, I go for the musculoskeletal setup because they give crazy good vascularity. in my machine. So I just check the testis, the left testis with the musculoskeletal setting and took the vascularity, and still we can see a good amount of vascularity. This is not the highest vascularity of orchitis, and this is not the vascularity of torsion. So it apparently looks normal. We should not be, because the testis is swollen and heterogeneously hypoechoic. You see some hypoechoic areas here, but there is no vascular changes. So why it's happening here? Now let's look at the epididymis. Now when we jumped into the epididymis, we can see it's swollen on the left side. You can see there is a very good vascularity. Usually the epididymis is very less vascular, and with Doppler, it feels difficult to see the vascularity unless you decrease the pulse repetition frequency, or PRF, quite well. So with this vascularity and swollen appearance, we can say, yeah, this is an epididymitis. But if it is epididymitis, the testis also should show a very good vascularity, but still it's not showing the very high flow of orchitis. Why it's happening? Let's jump into the grayscale view. I'm very unfortunate that I have forgotten to just save the video of Doppler. So it's unfortunate, but still I can just demonstrate to you. Look at the epididymis here. It's swollen, it's heterogeneous, but you have to look at this part. Let me freeze the image to describe you a little. So you see this part swollen, just look at that part. I will just try to demonstrate you. Look at this area. This anechoic area structure is the vessel. So check the orientation of that structure. You see, here you can see an onion-like appearance. Just these vessels are twisting at this point. So that is the area of concern. You see the epididymis is quite smooth here, but at this location, something unusual is happening. So just let me go. You can see the vessels are straight here. Okay, but here at this point, it's getting twisted. Okay, so here again, everything looks good. Just at this part, something abnormality is happening. So you see these vessels, they're straight, just going here and making a twisting. Let me just take any wear-like thing, which can be found in my table. Yeah. So just think that this is the epididymis. It's coming here, getting a fold like this thing. So that is what's happening. And I am just showing you this twisted area. So this is the area where the vessel is getting twisted. Now, why it's not causing any torsion in such situation? Because it's not causing a complete torsion. Rather, it just made an incomplete torsion in such case of acute epididymis. When it got twisted, the patient came with the feature of torsion, severe pain, and whatever. But fortunately, it got resolved by itself. So that's why the patient is having a very normalized situation right now about the vascularity of the testis. So this is the area. You see the epididymis is going here, now making a twisting at this point and then going here. So it's obviously a risky situation. Sometimes clinicians want to go for the exploration surgically and they want to fix that because it's still in a twisted condition. So if you put Doppler, you'll see the swelling or the whirlpool sign on Doppler. Obviously, because it's still having a twisting at that part, but it is not causing complete strangulation. So here, this is the part where the vessels are getting twisted, though it should be better if I could show you the video. So here you can see the vessels are having a round shape appearance at this point because they are in a swelling or whirlpool-like appearance at that point. So this is the site for the torsion, but still there is a good vascularity within the testis because it's not causing any complete obstruction. So this was a case of left-sided acute epididymitis with twisting of the epididymal vessels. And there was associated swollen and heterogeneous testes with apparently normal vascularity indicating resolved incomplete torsion state. Okay, sometimes you may see the testicular axis has been changed from vertical to horizontal. It may also happen. So there was also some reactionary hydrocele happening there. Okay, so this was a little bit unusual case. Usually the patient comes to us with epididymitis or with torsion, but this resolved state is quite uncommon in our regular practice. So let's jump into the case number 2. This is 58-year-old male patient who came with the left lumbar pain. Let's see what we have got on ultrasound right now. Here you can see this is the right kidney. Okay, it's 9 centimeter in length, quite normal for our age group. And the left kidney, though the picture is not good, but still it's 10 centimeter and looks quite not normal. You can see some hydronephrosis here. So we want to focus on the left kidney right now. So here is the picture. You can see the right kidney is showing about moderate hydronephrosis or grade 3 hydronephrosis. But when we try to trace the ureter is dilated. And if you trace it, we can see it up to the mid-ureter. And after that, we couldn't actually detect the ureter. I have skipped the urinary bladder picture because it was completely normal and we had no complaint about the urinary bladder or vesico-ureteric junctions. So we want to focus at the mid-ureter to evaluate further. Let's see the video. You can see the ureter is dilated. We want to trace it, but after this level, we couldn't see the ureter. Whenever you see an abrupt finishing of a dilated ureter, you should be careful. You shouldn't spend a lot of time searching for the stone only. Rather, you should focus in a magnified image. So here, if I look here, just let me freeze the image. Let me stop at this point. You see the lumen is anechoic, but at this part, the lumen isn't anechoic. It's slightly hypoechoic and something may be present at this part. So let's magnify the image. You may change the transducer. You may use high frequency. You may use the better quality transducer, whatever available for your machine. Now you can see here, this structure doesn't look quite normal. This doesn't look like a stone. Rather, you can see a hypoechoic irregular soft tissue area within the mid-ureter, and it is causing proximal dilatation. So this structure should be counted as a mass lesion, but we need to use the Doppler. So we will use Doppler, but let's see here. With color Doppler, have you seen ureteric wall vascularity on Doppler? It's not very common, or it's unusual. So here you can see a very good amount of vascularity at this part, and it is supplying this lesion. So obviously, this is an elderly case, and we want to go for an ureteric mass lesion here. So here's the magnified one. You can see very good amount of vascularity, mainly the peripheral vascularity, but if you check carefully, you may see some internal vascularity also. The vessels are very prominent. So it concludes it as a case of a ureteric mass. So we have used a power Doppler also, and still we can see there is a very good vascularity. Some neovascularization is going on. So it's not a good case. So here's the picture. You can see this is the ureteric mass. And yeah, it's a heterogeneously hypoechoic and obviously irregular, causing obstruction. It may be transitional cell carcinoma, which is the most common, whatever we get. So here's the vascularity again. You can see it is showing a good amount of vascularity. So this was a case of left mid-ureteric mass causing ipsilateral proximal hydroureter and moderate hydronephrosis. If you're new to our channel or if you're old to our program, don't forget to put your location on the comment box, because why not? We actually enjoy looking at your comments and knowing that you are connecting to our program from different parts of the world. And it's really a big pleasure for us. So let's jump into the case number 3. This is 28-year-old male patient who came with back pain. And there was a history of passage of calculi through urine. So that took our attention because whenever patient complains about urinary passage of calculi, it's really a disgusting case because we have to trace whole of the ureter. You have to search for the urinary bladder calculus. You have to search for the renal calculus. So it's quite not friendly. Okay, let's see what we have got on ultrasound here. So here's the picture on this is the right kidney, and looking at the right kidney, I think most of you have made the diagnosis. So unfortunately, this patient was diagnosed as a case of renal calculi. Um, yeah, it's not a case of renal calculi, but it's quite similar to that. Here you can see some echogenic structures casting posteroacoustic shadow. So whenever you see it, yeah, this is calculi, obviously, but hold on. You can see these calculi are not at the central part. Rather, they are located at the medullary region. This is the cortical region. This is the medullary region. And this is the central part, which is actually the renal sinus. You may also see some calculi at the renal sinus, which may be obvious because they may pass through the renal sinus and into the they may go into the urinary bladder through ureter, whatever. So these are actually the calcified area within the renal medulla, and we call it the medullary nephrocalcinosis. Whenever you see the case of medullary nephrocalcinosis on the single kidney, you should obviously search it on the opposite kidney. So here if it is located in a single kidney or the single kidney is affected, we think about a lot of different causes. And if it is seen in bilaterally, then we easily go for the parathyroid abnormality, and we need to search for that. In this case, if we can see that present in the left kidney. Okay, what else you can see? You can see some cystic areas here. These cystic areas are the cortical cysts, which is association here. Now, if I change the this presets and whatever, you can see, you can see the echogenicity of the kidney is more or cortex is just let me just adjust a little. Sorry for the interruption. um, okay, sorry for that. Okay, so if you look at here, you can see the echogenicity of the renal parenchyma is more than the adjacent or hepatic echogenicity. So it indicates that the patient is also associated with the nephropathy. And if it is bilateral, the serum creatinine may get increased. So we will have to go through many study with this patient if it is a new case. So anyway, here we have changed the transducer. Now you still can see the echogenicity is more than the hepatic parenchyma. You can see multiple cystic lesions, and there are diffuse echogenicity. Let me freeze the image. It's is it the calculi? If you look here, you can see some tiny flecks of echogenic structures. They're casting the shadow. So these are actually diffuse calcifications. So when they're located at a single point, they're actually showing you the appearance of calculi. But there are the tiny calcifications, which is found in the case of medullary nephrocalcinosis. So just echogenic flecks of calcifications. So anyway, if you use different transducers, if you use the linear transducer, this separation of calcifications may be obvious, but on our regular transducer, it may not be comfortable. So here's the picture of the kidney, which is the right kidney, and it is around 10 centimeters. So size is quite normal. And this is the tiny cystic structures within the parenchyma, and this one is the largest one. So these are the tiny cystic lesions. And the echogenicity is definitely more than the hepatic parenchyma, indicating nephropathy. Okay, so let's jump into the left kidney. And now it's obvious that the left kidney is also affected. So we want to go for the parathyroid hormone assessment and parathyroid scan whatever. So you can see diffuse echogenicity within the medullary region, causing posterior acoustic shadowing. You can see multiple cystic spaces, and you can see the echogenicity of the kidney is relatively raised. So let's magnify a little bit, and now you can see the similar features. So this is not a good case. So here you can see we have measured the kidney and it's of 11 centimeters. So the size is quite normal, but the echogenicity and parenchymal damage is obvious. So this one is the largest cyst of the left kidney, and it's around 16 millimeter. And you can see the tiny echogenic flecks of calcifications within the medullary region, mimicking the calculi. So this was a case of bilateral medullary nephrocalcinosis with associated nephropathy and cortical cysts. Oh, so only 3 cases have gone. Walaikum assalam. So thank you for joining. And let's jump into the case number 4. So this is a 28-year-old female patient who came with right lower abdominal pain. Let's see what we have got on ultrasound. Now here you can see this is a transabdominal ultrasound, and in the lower abdomen you can see a cystic lesion here. So the gain is quite low, so you can see the only a cystic lesion. I may have shown you the same case before. I have forgotten, so skip that part. Okay, so here we have put some Doppler, and on Doppler you can see there is no internal vascularity, but you can see some linear reticulation. So it may be a hemorrhagic cyst. We need to evaluate a little bit further. You can see adjacent ovarian tissue here. So we can easily use transvaginal ultrasound to evaluate further. So let's see the transvaginal ultrasound images. So here's the transabdominal ultrasound pictures, and you can see the appearance is quite similar to the hemorrhagic cyst. So let's see that this is the TVS image, and now you can see the lesion here. Ignore that. So the not ignore. So the uterus looks quite normal on the longitudinal section. You can see a good view of the endometrium, and the lesion looks quite larger than the uterus. So we took the measurements, ignored the errors of measurements. I just wanted to show you. Yeah, it looks quite normal. Let's jump into the left ovary. So here's the uterus, and you can see this is the left ovary. It looks quite normal. You can see multiple follicles. If you see multiple follicles arranged peripherally, don't say it a PCOD. So you need to see an enlarged ovary. This ovary is not enlarged. It is quite normal. So don't always try to say PCOD. It's a very obvious mistake we do. So this is a magnified image of the left ovary, and you can see multiple tiny cystic structures within this ovary, which are the follicles, and it's quite normal ovary. Now let's jump into the left one. You can see this left ovary is showing multiple follicles, and it's a big lesion here. Just let me freeze the image, go a little bit backward. You see, this is the ovarian tissue, and the lesion is connected to the ovarian tissue. So this is an ovarian originated mass or cyst, whatever you say. So we have seen a cystic lesion originated from the right ovary, and it has got internal reticular pattern. So we want to evaluate that again. So you can see internal reticulations, some retractile clots like thing. So these are actually a clot formation going on here. If you put some Doppler, you won't see any vascularity inside. You can see surrounding architecture is maintained. There is no fat thickening and whatever. So it's a typical case of hemorrhagic cyst, which goes in favor of Urer's score of 2 if it is less than 10 centimeter in larger diameter. So we want to go for a benign lesion here. Here's again another picture. You can see the moves inside with some prop pressure or the sound beam. So yeah, it's quite normal one. So we have used the Doppler. You can see some internal iliac arterial flow here, but there is, you can see ovarian flow at this part. But inside the lesion, there is no vascularity. Even these are the avascular clotted parts. So this is obvious that this lesion is a case of hemorrhagic cyst. So again, we have measured the lesion. It's less than 10 centimeters. So we'll go for the Ureteric score of 2. And there is no vascularity inside. So we want to go for a color score of 1. So we have took sample from the adjacent ovarian vessel, and you can see there is a moderate resistant flow here, which is very typical. Ovarian arteries or intraovarian vessels usually show you a resistive index around 0.5. So this is obviously a normal flow of the ovary. So this was a case of right ovarian hemorrhagic cyst, which goes with the Ureteric ultrasound score of 2 and color score of 1. Okay, let's jump into today's last case, and obviously it will be an obstetric case as usual. I have already got some congenital abnormality cases to share with you, but yeah, for one case per week, it will take long to finish. So anyway, this is a 32-year-old female patient who came with amenorrhea for 6 months. Let's see what we have got on ultrasound. This patient came to us on the very first day of Bengali New Year this year. On the if you are from my country, you know there's a 14 April case, and on the very early morning, patient came with a very good dress to see her baby and enjoy the rest of the day. So it was my second case of the day and first pregnancy case. So I was mentally stable to say a good report in such case, but I couldn't. So let's look at the image. Femoral length shows 21, 22. Abdominal circumference looks quite unusual. It's 26, and something abnormality is present here. And the head circumference says around 22. So of 21 to 22 for all, but abdominal circumference says that the abdomen is quite enlarged. So let's look at the overall fetal view. You can see there is no amniotic fluid. The fetus is situated within a gross oligohydramnios state. So no amniotic fluid. Whenever you see a no amniotic fluid state in 20 weeks, you have to understand that there is no leakage, history of no leakage. So obviously there should not be any production of urine. So you need to evaluate the kidneys. You need to evaluate the presence of urine within the urinary bladder. So let's jump into the real-time view. Now you can see unusual things going on here. So let me free, no need to freeze. Whenever you see some cystic areas within the abdomen, until proven otherwise, this should be originated from kidneys. So here you can see on both sides of the spine, these are the kidneys. These are enlarged kidneys. You won't see normal kidneys like this appearance. So these are quite enlarged kidneys, and you can see multiple cystic spaces within the kidneys. We make a simple or maybe a big mistake at this situation. Whenever you see enlarged kidney, you see diffuse cystic appearance. This is not autosomal recessive polycystic kidney disease. In case of autosomal recessive polycystic kidney disease, in gestational period, you won't see any cystic spaces. These are microscopic cysts, so you have to go for a biopsy, then in microscope you can see them. So there is presence of fibrosis and fibrotic bands and some tiny cystic spaces on microscope. So whenever you see cystic spaces in the kidney, in a large kidney, in gestational period, you have to diagnose it as multicystic dysplastic kidneys. We call it renal dysplasia because if you look at the renal parenchyma, you will see that the parenchymal liquogenicity may get increased. And these are dysplastic kidneys, so they won't produce any urine or may produce a small amount. So you need to check them. So we'll check the urinary bladder area to understand whether there is any presence of urine or whatever. So here you can see this is the fetal head. We have nothing to do with that. These are the cords here. We are searching for anything unusual present. So here's the kidneys, and this is the heart. Okay, so let's jump into another one, unusual image. We look at the lungs here. The echogenicity of the lungs look quite increased for us, but we don't want to make a comment at this stage. So we want to go for a follow-up in such case, because whenever you see any lung abnormality, you should search for the renal abnormality and vice versa. So we are not satisfied with the lung because the diaphragm doesn't look quite convex upwards, but still at this part we can see this convexity present. At this part we can see the convexity present, so we don't want to make any negative comment for this situation, but we want to comment on the kidneys. So these are enlarged kidneys with multiple cystic spaces, and you can see the whole parenchyma has converted into cystic lesions, and this is definitely a case of multicystic renal dysplasia. So here's the color Doppler. We put some Doppler and we tried to search for the urinary bladder in this patient. We couldn't see any urinary bladder. I think I haven't saved that image. Okay, so this one is not urinary bladder. Okay, this is the renal cyst. This is the renal cyst here. So don't make a mistake. You have to search for the urinary bladder. Why I'm saying this is not the urinary bladder? The urinary bladder will have a boundary in it will be situated in between two internal iliac arteries, from where it continues as the uterine artery. Umbilical artery. So here you can see this is the aorta supplying the kidneys at this part, and it is crossing this cystic lesion. So this is not the urinary bladder, rather this is the renal cyst. So you have to understand the level here. Okay, so we checked for the heart and there was no cardiac defect present. We expected some cardiac defects to be detected. We can't say there is no cardiac defect. We'll say that we have missed to detect the cardiac defects because there should be some cardiac abnormality present here also. But fortunately, we tried our best because the cardiac views are quite good in this case. So I think we haven't missed, but it may be missed. Okay, so these are the kidneys which are showing cystic spaces. You see some echogenic fatty area. This might be adrenal gland or whatever. So you see the renal parenchyma is completely damaged or altered with multiple cystic spaces. So this is bilateral multicystic renal dysplasia. Okay, you can see here, and this is the area for the urinary bladder, and there was no urinary bladder we could find during our 30 minutes of scan. So at least a few drops of urine should be present if the kidneys can produce some urine, but there was no urine within the this part. Okay, so this is a case of multicystic renal dysplasia. You can see both kidneys are enlarged. So this is the right kidney and this one is the left kidney. So it was breech presentation. So clockwise, it will be the right side, and this one is the right, this one is the left one. So the right kidney was a more in size, like 5.6 centimeter. It's very big, and the left one is the 4.5 centimeter. Both are enlarged with multiple cystic spaces. We tried to measure the largest cyst, which is not important, but we tried to measure just to make a report. So anyway, here's the picture we have taken with the 3D ultrasound. You can just take multiple slices with tomographic ultrasound imaging mode. You can choose the, we just have taken a cross section like or long section or coronal section, whatever you want. So it was the coronal section, and we took slice from the lower to upper part. Now the machine gave us multiple cross sections from different point, and you can see all those slices here. So we magnified the image, and now you can still see these images. So this was a case of 22 to 23 weeks of single life pregnancy with breech presentation and gross oligohydramnios or anhydramnios, you can say. There are abnormalities like bilateral multicystic renal dysplasia. The urinary bladder was empty during our 30 minutes of a scan with anhydramnios, indicating no urine production in this case. So a very little bit disappointing case to start the day with. So thank you for joining us today. Our next session will be on 9th May. So we'll skip the next session or next week's session, because the next week, hopefully, inshallah, will be in Taiwan. If you are from that part of the world, we have a presentation on the 4th, 4th May in Taipei. So if you are there, you may find me there. Anyway, so yeah, we'll update about that. So the next session will be on 9 May, Friday, hopefully. And if you are new to our channel or you have missed our previous sessions, you can get them easily on our YouTube channel. All the cases have been uploaded already. So, and again, our today's video will be uploaded tomorrow, so you can also get them if you find YouTube quite friendly for you. So anyway, don't forget to subscribe, obviously, because why not? And again, we have a website, though I don't use that much, unfortunately. So thank you for joining us today. And if you have any question, you can ask me in our Facebook Live. So thank you. So let me just check the comments a little bit. Walaikum assalam. If you find this video helpful, don't forget to share it with your friends, because that helps us actually to promote our Facebook page or YouTube channel. Though we don't get much earning from our YouTube program or even for the Facebook program, but still this promotion may help support our channel to grow a little more. And obviously it will encourage us to make our videos more. Okay, so thank you for joining us today. Hope to see you soon on our next session. So till then, thank you. I love this.